Hello again. Let's go ahead and get started now. And we really thank you for joining us today to talk about optimizing home and community-based services and supports, as well as healthcare spending at a time where there seem to be some budget constraints or looming budget constraints in Medicaid. So we're going to talk about some strategies that you can utilize to help optimize spending. I'm going to introduce myself, and I'll have our co-speaker say hello as well, and then we'll get started with the meat of the webinar. I'm Craig Escude. I'm a family physician. I started working in the field of healthcare for people with intellectual and developmental disabilities back in the 90s and learned a lot the hard way. I practiced over 20 years clinically providing healthcare to people with severe and profound levels of intellectual and developmental disabilities, and now work with IntellectAbility. We are a company that provides tools and training to supporters of people with intellectual and developmental disabilities to help identify health risks that are often missed and to improve overall health outcomes. I'm the author of the Clinical Pearls in IDD Healthcare, as well as an e-learn course called the Curriculum in IDD Healthcare, and host the IDD Health Matters podcast, where you can hear from leaders and self-advocates and clinicians in the field about the current state of IDD health. And I'd like to introduce to you my co-presenter today, Daily Talent.
Thank you, Craig. Hi, everyone. My name is Daly, and I'm a registered nurse. I have a little over 12 years nursing experience, with the last 7 years working with people with IDD. My background is as a provider nurse, and I've held leadership roles for provider agencies offering community, residential services, day program services, and just really have a passion for supporting people in those settings. I'm a proud member of DDNA and a certified developmental disabilities nurse, and I'm the clinical director at IntellectAbility.
Thank you, Daly. So the overview today, we're going to discuss how reduced Medicaid funding may impact people with intellectual and developmental disabilities. Then we're going to review 10 strategies to improve health outcomes while controlling costs. And then we're also going to offer some solutions to long-term sustainability relating to these strategies. I will point you to the handouts tab in your control panel, where you can download both the slides from today's presentation, as well as a white paper that discusses a lot of what we're going to be talking about today. So let's first talk about the Budget Reconciliation Bill, which was signed into law on July 4th of 2025. We know that in that bill, there are some reductions in federal, Medicaid, and CHIP funding. The estimate is somewhere around $1 trillion over the next 10 years. There are also some other provisions in there about work eligibility requirements, re-verification needing to be done every 6 months to ensure that you qualify for Medicaid services. And there are also some caps on provider taxes, which basically mean there will be less state funds available to use for Medicaid services. There are some potential broad implications. Overall, there will likely be reduction in funding to states for Medicaid services. And these changes, or how this reduction in funding will be different in each state. It will be affected greatly by how the state decides to manage these changes. And what we expect that we may see is that there's going to be a reduced expenditure on things that we consider optional services, things that aren't specifically required federally from Medicaid, but that states have put into place. These things include home and community-based services and waivers, and home and community-based service waivers, behavioral health services, and also some long-term care services. And this does obviously have potential implications related to people with intellectual and developmental disabilities. Now, just to give you an example from a state, I received this email recently from the American Academy of Family Physicians talking about North Carolina and a proposal to significantly cut rates, 3 to 10%, to balance the budget shortfalls in Medicaid funding, and that family physicians and other primary care providers would face an 8% cut in fee-for-service rates for Medicaid, a 3% cut to per member per month medical home payments, and likely cuts to value-based payments around quality metrics due to additional cuts to Medicaid managed care plans. So this is just one example in one small area of real things that are happening. And I'm sure you probably have many examples in your area as to things that are being considered. Now, when we look at the potential implications to IDD services and supports, we are looking at possibilities, and again, I'm saying possibilities because I don't think any of us have the answers right now on what's definite, but possible reduced funding access to, or reduced access to home and community-based services. This could look like a reduction in the number of waiver slots or a cap in the number of waiver slots. If that does occur, that could result in increased wait lists. There's concern over an increased risk of institutionalization, because if we lose community supports and we lose waiver slots for people who need more support and a higher level of care, they may only be left with institutional settings. There's concern over staffing shortages and even provider organizations shortages who may not be able to make it on reduced funds, or may be losing staff because they don't have the same level of funding that they did before. There's concern over behavioral health services, and there's also concern over increased administrative barriers relating to this re-verification every 6 months. We know that there are some populations that are stated to be exempt from the work requirements, but we still don't know the overall impacts of all of these things. These all can also result in a loss in some of this, each state that has specialized programs. Some states may have some Medicaid funding used to enhance or roll out supported decision-making initiatives, tech-enabled supports and tools, and even self-directed modules or models. So these are concerns, but I really don't like to focus on concerns. I don't like to, I don't like to operate by scaring things. I like to say, okay, this is where we are. These are the things that we're looking at. So what can we do? What can we do to optimize our expenditures on home and community-based services and supports and healthcare, while also improving outcomes? So what we've put together here are 10 strategies to consider, 10 things to implement. When you look at some of these, it many times, you might say, well, this is kind of common sense, or this one seems like common sense. Some of these may seem like, well, I haven't thought about that before. But even the ones that say, well, this seems like common sense, maybe putting a little attention to it and saying, okay, how can I do this even further, or take this even further? So, one simple example is something that we talk about a lot, and I think about a lot as far as, providing healthcare. When we prevent something, we improve a person's health, right? Because they're not going to suffer from a particular condition if we were able to catch it early and we were to prevent it. They may not have to go to the emergency room. They may not have to be hospitalized for that. That in turn reduces overall healthcare costs. So think about ways that we can prevent anything, any health related outcome. Look at methods to identify people who are at higher risk for health destabilization, because that will allow us to focus our resources, which might be more limited, on people that might be at the highest risk for having a bad health outcome that could result in expensive emergency care or hospitalizations. Look at health screenings. Are we doing preventive services in the level that we need to? We know there's a lot of documentation out there that people with intellectual and developmental disabilities have lower rates of preventive screenings for cancer and other things, sometimes lower rates of vaccinations, and really chronic conditions management in general. So are there things that we can implement to increase those rates of health screenings and vaccinations, preventive care, and chronic condition management, and optimize that care better? And also, we've got to think about our workforce. You know, when we train our workforce of all levels to be able to identify early signs of health destabilization, like can we recognize, for instance, in this field, we know that constipation can be a major problem. Do people who are, people who are on the front line, are they able to recognize early signs of a person that's beginning to have some constipation signs or respiratory issues or whatever it might be? Because they're going to be the ones to catch it and clue everyone else in early to put things into to do things to prevent these more costly and more challenging, and certainly leads to more suffering, right, in people that we're supporting. So those are a few things related to prevention. Now, we're always talking about data, using data, and now we have the ability to employ predictive tools and develop predictive tools that can help us identify which people are at more risk, not only for these health outcomes, but for costly health outcomes. And something that I'm really interested in and really looking to do more of is to focus on how can we combine, for instance, health risk screening data and couple that with claims data or data that states may have to identify which people are more, for instance, might be at a higher risk of hospitalization in the next 6 months or in the next year. Again, to help focus our efforts on prevention. Cross-referencing that health risk screening data with Medicaid claims data, I think there's a lot of potential for that, and we're exploring these possibilities now and even developing dashboards for real-time monitoring that use all of the data that we have available. And goodness knows, if you're providers out there, that you collect a ton of data. You collect lots of measurements in, vital signs and weights and hospitalization information and all these records. And it's how do we harness that data and use it to help us prevent these, significant health outcomes and costly health outcomes as well. And the better we learn to utilize it, the more preventive actions we can put into place. Care coordination is another big area. There are so many arguments we can make for integrated care or coordinated care, where we have all aspects of healthcare being utilized to address the person as a whole, looking at physical health conditions and behavioral health conditions and psychiatric conditions, and how do all of these things interrelate. And I would say that for people with intellectual and developmental disabilities, it's even more important to have integrated behavioral health and medical care and oral health care, because so many times all of these things are related, and so many medical conditions cause behavioral challenges, which end up on a person seeing a mental health provider and maybe even starting on a medication for adverse behaviors when it really was an underlying medical condition. And the better coordinated we are in providing care and having clinicians who understand how to provide good health care for people with intellectual and developmental disabilities, the better we will be able to identify causes early, understand the actual cause of a person's challenges or health conditions, and then be able to work to improve those before they become long-term problems for that person, and again, result in costly outcomes. So using our interdisciplinary teams, enhancing their ability to connect, to share information, having a document maybe that looks at health risks that can help all of these different entities or different silos of healthcare communicate together in a way that will help them improve care is something else to certainly look at. Technology. We talk a lot about technology. I just did a presentation at the HCBS conference on technology and integrating technology into supports and services for people with intellectual and developmental disabilities and how states are doing this. There are so many aspects of technology that we can talk about, from technology that can help support a person more independently, that can reduce the number of staff that are needed by using technology to say to do remote monitoring, for instance, can be very helpful. Implementing behavioral health and telehealth, using experienced telehealth providers, IDD experienced and trained telehealth care providers, can be very helpful in terms of reducing transportation costs and catching things early and preventing unnecessary emergency department visits. Automated data entry alone can save time. Being able to import medications and diagnoses throughout different platforms and having them connect and talk to each other can reduce this duplicative effort and administrative burden that we already see. So look at ways to employ technology as you continue to support people. Value-based payments, this kind of can be looked at in a couple of ways, and there's some current concern sometimes over that, and I get it, but it's a shift from really from models that are more into volume to models that reward these preventive efforts, reward stabilizing health and quality of life improvements. And you can look at outcomes related to hospitalizations and emergency department use, and outcomes related to community inclusion for people with IDD. And we're going to touch a little bit more about value-based payments, and there's also more information about value-based payments and examples of some that can be utilized in the white paper that we have available for you to download. So value-based payments can play a role. Certainly strengthening and doing whatever we can to retain the workforce. We've all heard about this for a long time because it's been a difficult thing for a long time. But we know that when we train our workforce, when people are trained, they have a higher rate of job satisfaction. They're more likely to stay in a job. So providing training, especially for frontline staff, who, none of us are born with the ability to recognize health risks, right? Especially in people that may communicate them differently. There are special techniques and skill sets that we can learn to help identify health risks early. And we've got to train our support staff to be able to do that. So look at programs to provide this training or different levels of certification. Organizations such as the National Alliance for Direct Support Professionals has an eBadge Academy, but looking at investing in training to strengthen and retain our workforce. Using scheduling platforms, this kind of can get back to technology to help avoid burnout, and maybe developing career ladders. And again, I will say many of you are probably doing a number of these things already, and there are things that we can do and things to continue to think about, and what can we add, and sharing those things with others. Number 7, reducing the use of high cost settings. So we think about high cost settings, immediately we think about hospitalization. But in terms of IDD supports and services, maybe there's an option such as a crisis stabilization service that's in a community setting for someone that may be having some behavioral challenges, rather than an inpatient psychiatric hospitalization. Doing things to reduce reliance on institutional care, looking at targeted transition planning. We know that people who have higher needs may gravitate more towards institutional care, or it may be felt sometimes that they can only be served in an institutional setting. So doing what we can to help keeping people healthy can reduce reliance on institutional level settings as well. And then, training providers an alternative to emergency and inpatient care. Are there other options? Can we keep people in homes and provide the same level of care. One example of this might be, again, utilizing an IDD-specific telehealth service to provide telehealth clinician and physician level service in a person's home that can reduce the need for maybe an emergency department visit. Another area to consider is addressing social determinants of health. You know, it's been nice to see emphasis placed on this over the past few years, and we're hearing more about it. And these are non-medical determinants of overall health. Things like having enough food, having healthy food, having housing that's safe, that's having neighborhoods that you can get out and exercise in and walk in. You know, are there things that we can do to fund non-clinical supports such as housing and food and transportation and so forth using Medicaid flexibilities? I know there's been some changes in SDOH and changes in codes and reimbursements moving away from some of these things, but it's not complete. And there's certainly some options that we can all employ, I believe. One thing that we can certainly do is screen for these social determinants of health. And one of the things that we did, we'll touch on this a little bit more when we get into some of the solutions, is we actually developed an SDOH screening specifically for people with intellectual and developmental disabilities. That's available free on our website, and also as an option built into the health risk screening tool. So certainly addressing these areas of health that impact health can be something that we can focus on as well. You know, we can always cut inefficiencies, right? And so it may be time to look at that again and say, wait, are there services that we're utilizing that aren't being helpful, that aren't being beneficial, that we're spending money on? Are there duplicative services? Are there unnecessary services that we're actually providing? You know, looking at realigning provider payment rates to the services that a person actually needs. Can we utilize an objective tool, for instance, to help determine what level of service someone may qualify for? And we may find that some people qualify for a higher level of service, which is needed, but we may also find that some people qualify for a lower level of service because their needs aren't as high as we thought they were. So looking at things like that and using tools and objective tools to be able to do that, and looking at clinical decision tools to guide resource allocation can be helpful as well. And then the last of the 10 here is really involving people with disabilities and their families. Person-centered care is more effective, it's more efficient, it's giving people what they want. You know, going back to value-based payments, if you want to know how to develop value-based payments, one of the first things you should do is ask people that are affected by it, what do they want? What are they looking for? What do they want out of their services and supports? And then develop measures around those things. So you'll use tools and practices that support person-centered thinking, train support staff in these areas, empower people and their families to participate in goal setting and service design. And again, I know many of you people, I know many of you do this already. But continue to do that and enhance that where you can, and align those services that we provide with the services that people actually want and then they actually need, and that align with their life goals. So those are 10 strategies to look at implementing or enhancing in the work that you already do. Now we're going to talk a little bit about IntellectAbility and the role that we can help with in achieving some of these strategies. So just to give you an overview, IntellectAbility is a company that is completely built on identifying often missed health risks in people with intellectual and developmental disabilities and other at-risk populations, and helping people to identify those and then to act upon those to reduce those risks and improve overall health outcomes. We do this through our health risk screening tool. We do this through our academy, which is filled with e-learning courses to train supporters. And then we also do this through person-centered services, through person-centered training for states and agencies. I'm going to now turn it over to Daly, who you met earlier, to give us some more details about these different services.
Thank you, Craig. So I'm really excited to talk about our sub-brands. I'm starting with the health risk screening tool, also known as the HRST. I had the privilege of using the HRST when I was a provider nurse, so I could actually see how the tool helped people with IDD and their families. It also streamlined workflows and person-centered planning for the agency that I worked with. So what is the HRST? It's a web-based tool that's used to catch early signs of health risk and health instability, especially for people with IDD, but other at-risk populations as well, including people with physical disabilities, traumatic brain injuries, the aging population, children, and really any at-risk population can benefit from the health risk screening tool. I do want to point out that the HRST is not a clinical assessment. It's a screening tool, and it can be used by non-clinical supporters. So it works by having 22 items scaled, and the 22 items are designed to identify the people who are at the highest risk of health instability and illness. Once the screening is complete, the HRST then provides action steps that the support team can take to reduce the person's identified health risks that are specific to them. And these action steps are called the service and training considerations. So this slide shows the 22 rating items, and they're separated into 5 different categories. So functional status looks at the person's activities of daily living. How do they eat? How do they move around and transfer and use the bathroom? The second category is behaviors, looking at those specific behaviors like self-injurious behavior and aggression that can point to underlying medical issues. And that category also looks at the use of psychotropic medications. The physiological category looks at specific body systems, including the fatal 5 conditions there. We have our safety category that looks at the frequency of injuries and falls. And then lastly, we have frequency of services that measures how often the person is needing to access community healthcare services for their acute or chronic health issues. This is the HRST rating scale. So each rating item is going to be scored from 0 to 4. The higher the score, the higher the person's health risk in that area. And the scores make it very easy to see where the person's risks are. So you'll see this is an example of each rating item being scored, and I can easily see that item K, gastrointestinal, that person is scoring high there. I can identify that risk easily, as well as bowel function and emergency room visits. And then once each item has been scored, the person's healthcare level is generated. And just like the scores, the higher the healthcare level, the higher the person's overall health risk, and the higher their risk of dying. And as Craig mentioned before, we have so much data that we're looking at on a regular basis. So the next few slides are going to provide a visual of how the HRST helps us organize all that data that we have for the person and help us to use it in a way to support the person to have better health outcomes. So the data is aligned into categories, and then we can, again, quickly identify where the person's scoring high and focus our attention there. Once the screening is complete, then the data is moved into the service and training considerations. The service considerations suggest the assessments or clinical evaluations that might need to be done to reduce or even eliminate the person's risks. And for each service consideration, we're going to get a training consideration, areas that we can educate families, staff, and even the person on to better help their health and wellness. And what I think is so valuable and important is that the considerations are person-centered. So we can use them to build a meaningful person-centered plan and not just a cookie-cutter plan that I'm sure we've all seen in our work. The HRST, it's validated, it's proven, and it remains reliable year after year. And 2 research studies found a statistically significant correlation between the HRST healthcare level and mortality. So with each healthcare level increase, the person's risk of dying increases as well. And on the next slide, you'll see a graph here, and it shows that increase, that correlation between the healthcare level and mortality risk. The study is done every year, and the graph depicts the last 10 years. The healthcare levels are across the bottom with the mortality rate along the left, and you can again see that correlation. Another study was published in the Journal of Nursing Measurement and had a great conclusion that is again supported by the data, that the HRST can predict mortality, and therefore it can serve as a basis for establishing healthcare needs and determining nursing care acuity. But the HRST can also help states and agencies in many other different ways. So the rating item scores, those individual 22 rating item scores and the overall healthcare level can be used to stratify risk, which is going to help in prioritizing those wait lists in an objective way based on actual health needs. And because the HRST is a living, breathing tool, we can monitor the person across their entire lifespan, and then we can adjust programs or services as needed. And it's all about being objective, and we can have an objective way to see who does or doesn't need those additional services, the clinical services, the additional case management services. It helps with assigning those caseloads. And then we have a state that uses scores and sometimes the healthcare level to help determine that case management support. You know, does the person need quarterly visits from case management, or do they need something more intensive like monthly visits? The HRST, it has a report suite and a data dashboard that gives organizations the chance to monitor specific aspects. You can even drill down to certain locations within your organization or groups of people, and then you can focus quality improvement efforts there, like maybe you want to address falls or look at the fatal 5 conditions. And then Dr. Eskide mentioned the importance of using technology wisely and how providers should look for opportunities to share information electronically to improve that care coordination for the people that they support. And one example of that is health risk informed telemedicine. And this is where a person's HRST screening information is shared with a station MD healthcare provider when they're receiving that IDD-specific telehealth support. And this allows the physician to see the person's health risk profile and can help them make clinical decisions based on the person's health risks. And next, here's some outcomes about the HRST, proven outcomes from agencies who have implemented the tool. And in a year's time, one agency experienced a reduction in unnecessary medications, a decrease in healthcare levels across their population. So that's huge. We talked about the healthcare level being associated with mortality. So they basically added years to the lives of the people that they support. They noticed a decrease in falls, a decrease in ER and urgent care visits, and that alone warranted some significant cost savings from a reduction in those unscheduled ER visits. And then a region within a state that uses the HRST noticed one of those considerations, one of those action steps that are produced by the HRST. And it was telling them that the people that they were supporting, they were scoring an item K because they were having hand mouthing. So the region put forth an effort to have those people that were hand mouthing seen by gastroenterologists. And many people were seen, they were actually diagnosed with GERD. They saw a decrease in their behaviors, including hand mouthing, and then several more of them were able to be weaned off psychotropic medications that they were prescribed for those behaviors. So some proven outcomes here using the HRST. Next, we're going to talk about our second sub-brand, which is the Academy. So our Academy provides credential training to all levels of supporters, and our most common courses cover the Fatal Five. And the Fatal Five, as we know, are those top preventable causes of death in at-risk populations like aspiration and sepsis. And these courses, they teach DSPs, nurses, and case managers how to recognize signs of these conditions and what to do about them. And we also have a whole list of courses there that are pertinent to health and safety. We also have our productions where we can produce custom e-learn courses. So we've done medication administration courses, we've done courses on how to support people that are hard of hearing, and recently we helped a state develop their IDD provider manual into an e-learn course. And it's just a really great way for providers to interact with the manual beyond just that thick reamed book. Next, we have our curriculum in IDD Healthcare. And another focus of IntellectAbility is educating clinicians and healthcare students in providing care for people with IDD. And Dr. Escude and I, we can both attest to the fact that we did not receive any training in our respective healthcare programs about how to care for people with IDD. So we want to put this training out there for clinicians and future clinicians so we can kind of bridge those knowledge gaps. And then that course is credentialed. We have CMEs available for the course, and it gives clinicians information that they can use immediately in their practices. And then our third sub-brand is person-centered services, where we offer person-centered thinking training in partnership with the learning community for person-centered practices. So if you're wanting to really shift your agency's culture to one that's person-centered, we can help with that. We can provide person-centered thinking training in a virtual or e-learn format, and then we can help credential trainers and coaches within your organization so that you can teach person-centered thinking training in-house. And it just becomes a culture and everyone's on the same page, putting the people that you support at the top and really improving health outcomes and happiness. And with that, I'll turn it back to Dr. Escude to review how our services can help with those 10 specific HCBS and spending strategies.
Thank you, Daly, for that great overview. So let's talk a little bit about how some of these tools and training can help with some of these specific strategies here. When we recap the strategies, we're looking at putting prevention first, utilizing predictive insights, enhancing care coordination, leveraging technology, looking at value-based payments, developing and retaining staff, minimizing high-cost care, addressing social factors, reducing inefficiencies, and promoting person-centeredness. So you can probably already put things together to see how the HRST and the training can really help with these things. When we look at preventive interventions, we know that the HRST was specifically built to identify health risks and inform supporters before these health risks become big health problems that result in unnecessary preventable hospitalizations, emergency department visits, and unnecessary suffering by the person. Looking at predictive analytics, when we combine, we want to combine our information with claims data for states or organizations and then use it to predict which people are most likely to have these outcomes so that you can then focus your interventions on people that are most likely to have these high healthcare needs or unfortunate healthcare outcomes. In terms of care coordination, the HRST risk profile and considerations can really be a document that improves conversation and provides almost a language related to health and health risks that the support team, along with the healthcare team, and talking about that integrated care model, how that can they can all use that same document to be able to communicate better and see who's addressing what and what are the more important areas to look at. What technology integration? The HRST has data automation capabilities. We've talked about sharing this data and making it available at the time of an IDD telehealth visit so that the clinicians are informed by the person's health risks at the time of the visit that can help with their clinical decision making. We have abilities to import medications and diagnoses from other systems or directly from pharmacies, not only reducing duplicative effort, but also to ensure accuracy of this information because it's coming straight from the pharmacies. The reporting capabilities, when again using that data, and HRST has a very robust reporting suite that allows for oversight at a state agency or a provider level to identify areas or agencies that might be experiencing higher levels of different conditions, and to help them target their resources where they're most needed. Value-based payments, I will show you a couple of examples of how some states are using the HRST for value-based payments, but you can look at different aspects of the HRST and use them as a measure of quality. And again, I'll touch more about that in just a second. And workforce efficiency, the practical competency-based credentialed training is available through our academy for all levels of supporters, from direct support professionals to nurses to case managers. All of this can help improve clinical oversight, reduce errors, and promote staff retention. And again, we also have that physician level course, which can improve overall competency in your area or with clinicians that you work with. Avoiding high cost settings. We know that if we can identify health risks early and put in preventive actions, we can reduce unnecessary hospitalizations and emergency room visits, and potentially even reduce unnecessary behavioral health crises that maybe are resulting from unmet needs, and a person is experiencing pain, and the only way they're able to express their pain is through adverse behaviors. So if we can identify these things, we can reduce those also. Social determinants of health and person-centered care. The HRST platform, as I mentioned earlier, we have built an IDD-specific social determinants of health screen. You can download that free on our website, on our resources page at replacingrisk.com, or it's also available in the health risk screening tool. Person-centered teaching, thinking, training, all of those skills in helping people to support people to meet their needs. There are studies from Council on Quality Living that talk about when people are in environments where their needs are met and what they want for their lives is considered, there are actually reductions in adverse behaviors and even reductions in things like emergency room visits, which is pretty impressive. We're going to touch a little bit on some of the IDD-specific quality measures. I will point you again towards the handout where there's more information on that. We want to save a few minutes for questions here at the end. But when we look at value-based payments, what is it? It's basically paying for quality and positive outcomes rather than just a volume of services or how many services we provide. And it's really becoming more of an essential strategy now to improving healthcare quality, outcomes, and equity. And it shifts the focus towards proactive, person-centered care and helps people to be accountable, to show and to demonstrate that they're meeting certain goals and providing a certain level of care. And it helps to ensure that systems are delivering the right care when it's needed at the right time. And a couple of states are using the HRST specifically, looking at the current HRST screenings. Are they current? What is the percentage of screenings that are current, for instance? So just ensuring that a person has a screening done. Then also looking at things such as, are people utilizing the data from the HRST and those service and training considerations to improve those outcomes? How are people using that data? Showing that they're using the information to reduce those health risks. And then demonstrating the use of the HRST data to create and conduct wellness programs and activities as well. So looking at these as measures and setting thresholds for people, for maybe an agency to meet these threshold, and then providing an incentive payment based on that. In terms of training, one state uses it to look at the number of case managers that are trained using the Fatal Five, that have completed that training, or the person-centered thinking training, and for nurses who have completed that Fatal Five advanced training. So setting a threshold to ensure that nurses are meeting or completing that training, and then providing an incentive based on that. So recapping what we've talked about today, we've discussed 10 strategies for optimizing home and community-based services and healthcare spending. We've looked at some IDD-specific value-based measures, and also how tools and training from IntellectAbility can assist in optimizing these expenditures and outcomes for states, for providers, and for people with intellectual and developmental disabilities. We're going to get to a couple of questions. Again, I do want to remind you about the handouts in the handout section, the white paper, to download that. And if you'd like the slides, they're also available in the same area. And so we've got a few questions here that I'm going to go through. The first one is the HRST available to families, caregivers, and support staff, or just healthcare staff? So to answer that question, the HRST is made available to provider organizations and to state developmental disability agencies for use in people that they support. So there are many staff and caregivers that utilize the HRST, but it's through a provider agency. It's currently not available for, say, one-on-one licensing, but that is something that is interesting, and something that we are considering. And hopefully, I'd love to see that developed in the future. Let's see, what have been successful strategies in marketing these tools to organizations and facilities? How do you communicate the value? Well, by doing exactly what we're doing today. We meet regularly with state developmental disability agency leaders and provider organizations. We attend all of the national conferences and many state level conferences in the intellectual and developmental disabilities and home and community-based services field, specifically to meet with states and people and organizations to make them aware of the tools and the training that we have, and help them to see how it can be used in support of people with IDD. And we certainly always welcome referrals. So if you know someone that you would like to have learn more about our services, we'd be happy to reach out to them as well. All right, another question. Can you speak more about how the training supports staff retention? So there are a number of studies out there that point to the fact that when staff are better trained to do their job, they feel more empowered, and they have more of a sense of belonging to the organization, and they are more likely to stay there. And you can imagine, just from a practical standpoint, if you are let's say a young direct support professional, and it's your first couple of weeks on the job, and you have someone that's having very challenging maybe behaviors, or you're charged with identifying if someone is getting sick or not, if you're better trained to be able to do these things, you're going to feel more confident and you're going to feel more empowered. And there are studies that show that it does point towards retention. All right. And the next question is, can you show us where the SDOH is located within the HRST? I will say that this is in some markets right now. If it is not, if you are currently an HRST user and it is not in your market at the moment, please reach in to the help desk through the HRST and we can work with you to get that into your market. But you can definitely download it from our website on our resources page in the meantime. Does the HRST interlink with documentation systems like TheraP? The HRST can be integrated at different levels, from full integration to smaller levels of integration with any system that's out there. We've successfully done this on a number of occasions. It all depends on which system that you're using, and if you'd like some more information on that, again, reach in through the website or send an email to info@replacingrisk.com and we can help you with that. And let's see, how do we find out which state agencies have access to your assessment tool? California specifically. We are a vendor agency. I'm interested in utilizing this tool. Thanks. So thank you for that comment. And we can reach out to you to get more information. It has been used a little in California, and we are actively looking to expand the use in California. Currently, it's used in 26 states. There are about 10 states that utilize it across the entire waiver population. These are states such as Georgia, Maryland, New Hampshire, Illinois, Pennsylvania, Kentucky, and a few others, but yeah, we're happy to talk with you to learn more about it. So that looks like all of the questions that we have so far. If you have any other ones, we've got a couple of more minutes. Feel free to pop them in. While we're waiting to see if there are any more questions, we would love for you to connect with us on social media. You can also subscribe to our newsletter on our website, or by scanning the QR code there. I want to also let you know that we have a series of free webinars where we discuss specific health and wellness and support related topics for people with intellectual and developmental disabilities. The next one is coming up on October 7th. We always have a guest. Our guest for this one will be Dr. Matt Holder, and we're going to talk about reasons people with IDD, open quote, don't act right. So there are a number of those reasons, and we'll get into those on that webinar. And we've got several others lined up, so you can scan that QR code or visit replacingrisk.com and click on webinars. And the podcast, I don't know if we have a slide on that or not. I don't think we do, but if you just search IDD Health Matters podcast, you can find it on any podcast platform, and Apple Podcasts, or on YouTube has a video version. We've got well over 100 episodes out right now. And again, I talk with state developmental disability directors, provider agency leaders, direct support professionals, nurses, physicians, dentists, case managers, family members, people with IDD, self-advocates. So a wide range of topics are covered on that. So we'd love for you to join us. And if you've missed previous IDD Perspectives webinars, we are putting those out on the podcast as well too. So I really appreciate the positive comments there, and we very much thank you for taking time out of your day to join us and to learn more about how we can all work together to really improve. Mostly what we're doing is improving lives of people, right? Preventing unnecessary suffering, helping people to live healthier lives in a way that empowers them to live lives that they love. But in turn, when we do these things well, we also utilize resources and funding to the best of their ability, reducing costly outcomes. So again, thank you for joining us. I very much appreciate you, and enjoy the rest of your afternoon. You also see our email addresses there. Feel free to reach out to us directly.